I'm Ravijyot. I am a medicines optimization lead pharmacist, but also respiratory pharmacist by background. I'm currently in a community trust, and I've done lots of other bits and bobs and wear different hats for national roles as well. So today we'll be talking about respiratory related things, but with a sustainability lens. I'm also going to turn my camera off because there's a risk of breaking the internet, which might well happen at my end. So can somebody, so if Emily can, as she said, keep an eye on the questions, feel free to put questions as we go along. I'll take them at the end. And can you just tell me if my slides have moved for you?
Yeah, they've moved to the outline. It's still on. You're still on the slide. You're not on slideshow view. I don't know if you want to be on slideshow view.
I'm going to leave it just because it will freeze, which is what happened last time, and then that way the slides won't move at all. So I think everybody hopefully will have had a message pop up that we're recording, so hopefully you're all okay with that, and I'm just going to get started. So thanks everybody. As I said, I'm going to be talking about lots of things. Anybody who's heard me talk before, I always talk about holistic care and quality care because that's really important to me, and ultimately what we're doing is for the benefit of patients. So I will be running through all of these things. So talking about climate change, thinking about the impact to respiratory health, also some of what the national respiratory drivers are and other strategy documents, a little bit on shared decision making, and then the role that pharmacy teams play as well. So what I want to just start with is that you've got this nice little cycle at the side here. Just have a look at that for a minute and think, whereabouts are you in terms of respiratory care or sustainability care? I mean, are you engaged? Are you doing things actively around sustainability, or are you just aware of stuff and you're hoping to just learn a bit more today? So it'd be good to see where you are in that cycle, and I'm going to tell you what I think about what some of the real world issues are with delivering respiratory care on the ground as well. So often I hear from people, we just don't have time, we're busy, we've got competing priorities, people have got a different perspective of what needs to be done, and sometimes in sectors it might be different. In primary care there's more of a push to reach a particular target because there are incentive schemes, or you've got a QOF, and in hospital it might be slightly different. In other services it might be a different priority as well. Amongst all of that, we've got to think about the resource to be able to deliver effective care as well. Some of that resource might be actually staff, it might be access to equipment and so on, and services. But really it's about what the staff understanding is, what the patient expectations are as well, and what supporting materials have we got to deal with the things that we want to do and deliver the care that we want to give in an ideal world. So these are what I think the respiratory issues are, and I think most people would agree with me, and if anybody thinks differently, it'd be interesting to hear. We know that there is a lot of SABA over-reliance, so that's short-acting beta agonist, so people overuse salbutamol, and that might be for a number of different reasons. We know that people are non-adherent. It might be that there is just more of a reliance because they think it's going to work, so there's some underlying psychological things that need to be unpicked there, but actually people often aren't on the correct treatment. They're underusing their treatment for asthma. So this is, respiratory generally, but for an asthma treatment regime, you're going to need something that is ICS containing, so inhaled corticosteroid. We want people to be on the correct maintenance therapy, and if it was COPD, it might be dual bronchodilators as well. So that way, if they're using the regular therapy, that means that there's less need to use the short-acting, which is really meant to be just there as a PRN breakthrough, like you might have for pain. And the idea is that the pain is controlled so that the airways are controlled, you're not needing so much of this. And if we have appropriate disease control, that is better for the environment, it's better for the patient and their outcomes, and we want to prevent exacerbations, because each time somebody has an exacerbation, certainly for COPD, it knocks off a little bit of their lung function, which is not good for them. I've mentioned non-adherent, so people are non-adherent for a number of different reasons. I'll come on to that briefly as well. And we know that people just have poor outcomes, especially in asthma. There's lots of data around that, and I'll allude to some of these documents in the coming slides. We've got people who might have more severe disease, like severe asthma, and therefore they need to access specialist services and the correct medicines. That might be biologics, it might be just more of a kind of run through and deeper dive into their care. It might be that it's more nose related. So there's a bunch of different things. And do the patients get this all? Do they kind of get lost in the sea of other patients, and do they get the care that they need? And possibly not. We know that smoking is still an issue, and within that we've got vaping. So we want people to be able to stop smoking at any point in their disease trajectory. This is going to be helpful for them, whether it is respiratory disease or otherwise. Smoking is linked to cancers and so many other things as well. Breathlessness is a big part of respiratory disease, and we also have other social determinants of health that we need to think about that we might feel that actually we can't fix because they're not part of our remit. But we are health and wellbeing practitioners as well, so we've got to think about the air quality, which is indoors as well. So if somebody is a smoker, that's affecting the air quality in somebody's immediate environment. We want people to be living their best lives and stay as fit and healthy as possible. Amongst all of that, we need to think about polypharmacy as well, and we don't want to overprescribe. And we've got a tired, busy workforce who we're expecting more and more from, and there is a real variation in their skills and what they can do. And so we want them to be standardized. And if we think about the upcoming prescribers in 2026, we're going to have a whole raft of new pharmacists launched into the world who are going to need support. And so we need to be appropriately skilled to be able to support them as well. So if I just give you some figures here. So if somebody were to visit their GP, that's 66 kilos of carbon emission, which is not good. But that's pretty much doubled if they're needing a single day of acute care. So what we want to do is keep people as well as possible and keep them at home appropriately well and not overuse health resources unless it's actually indicated. So part of that is supporting self-management for them. So I'm just going to share a couple more pictures here, and this is nothing new to us now. Unfortunately, we've had really poor weather, winds and rain and all sorts this last couple of weeks, and this is only going to get worse. We have no plan B, we've got no planet B, so our only real action is to take action and stop things going to the extreme, which is where we're heading. The temperature rise of 1.5 degrees, we're looking to exceed that, which is going to be dangerous to human health. So this is an existential crisis, and we have a code red for humanity. So what I want to just show you a little bit more about, and this is not necessarily just respiratory disease. Climate change has an impact on human health. So if you do have underlying cardiopulmonary disease, you're going to be more predisposed and feel the effects more so. And so again, this is then potentially more inequalities and people having worse outcomes if they got a particular tendency. But as you can see here, this is asthma, this is mental health, this is all sorts of diseases, not just respiratory and allergies, and thinking globally as well. So where we might have had different insect species, they might be changing, moving, and you might have more waterborne diseases as well. So you need to think kind of like in a global sense. So you might have seen this. This is from the World Health Organization, and it outlines climate-sensitive health risks and vulnerability. So we need to start thinking about climate change in a different way and look at our kind of resilience and what we have and what we can plan for in terms of business continuity, and look at how our health systems are set up and how we provide the care. So that is some of the mopping up, but we want to think about preventing this as well. And so prevention in a number of different ways. Now, those of you in the know will have heard of the countdown report, the Lancet countdown, and very excited that the 2023 Lancet report came out today. Unfortunately, I was doing another presentation at the same time as the global launch webinar, so I don't know if anybody attended, but it is quite a kind of sobering read, and it's telling us about the impending doom. But we still can do something to try and help our planet, and it's everybody's business. It doesn't matter whether you are a respiratory interested clinician, if you are a lay member, a patient, whoever. It's everybody's business, and remember, we've got no plan B. So I'd recommend everybody have a look after the meeting. Just have a look to see what the report says. It's fresh hot off the press, and then you may have seen these as well. So again, I'm thinking globally, and I mean globally across the world, but globally across healthcare. We've got the Sustainable Development Goals, the SDGs. And these are describing a number of different things. And we're very lucky that we're not a developing country here in the UK, and we're able to think a lot better. So we don't worry about waterborne diseases, for example. However, there is poverty. There's a bunch of different things going on. And so we need to think about this and the SDGs when we're thinking about our emergency preparedness and resilience and our infrastructure to be able to cope with the upcoming changes, which will no doubt will start to feel them more and more. So just going back to respiratory and the impacts to climate, to health, respiratory health here. So this little picture really explains nicely. So everything's interrelated. And if we think about COPD, that's related to smoking and also biomass fuel exposure. We've got people who have come over here to work from other countries. We've got people who are refugees. We don't know what exposures they've had. And we still know that today on World COPD Day, we've got still 2/3 of the COPD population out there just not diagnosed. So that's the missing millions. That's 2.2 million out there. So we're going to have more pressures on our health services anyway. We know that people are living for longer, but with poorer quality of life. And especially if you've got asthma or some sort of underlying allergy or respiratory problem, you'll have different levels of pollen and allergens and mold as a result of the varying weather changes, which is then going to irritate people's lungs, make their disease control potentially worse, and give them more infections. And also what happens is you end up with more ozone at ground level and also particulate matter. And there's the PM 2.5, particulate matter 2.5, which is a particular bad guy. And there's no safe levels of that. So the World Health Organization have told us that already. So we just need to be really careful. I'm thinking about fires and forests. So for forests, I mean, it takes many years to grow a forest, and a fire can just wipe, so many years worth of growth out just in one go. And these fires can actually, with wind, the particles, the smoke, that can really travel for hundreds of miles. So you could be in a faraway location, but still feel the effects of that, which you might be surprised to know. I also just want to mention health inequalities here. So hopefully people have heard of the Core 20+5, which is the NHS England strategic approach towards health inequalities. And the reason I'm mentioning this is because we have unwarranted variation in respiratory care across the country and across the world. But I mean, if we think within particular ICSs as well. So the climate crisis is a health crisis for a number of different reasons. And so what I'm talking about today is that quality care for patients, and it's holistic. So this is not just changing something in one area in one ICS. This is a whole system approach across the NHS and lots of cross-cutting messages, and thinking really about the principles of making every contact count, whether you are seeing a patient in a community pharmacy or any other setting, or it might even be a friend or a relative, drip feeding positive messages around health and sustainability. And as I said earlier, high quality care is sustainable care as well. So there's a number of things that we need to do across the NHS and personally, I think. So this is going to be all happening in tandem. So some of it is a marathon and some of it is a sprint. We want to think about really the care fundamentals. So some of that would include making sure we've got the correct diagnosis so that we know what we're treating and that we're coding people correctly. We want people to be stopping smoking, and so offering the treatment, the support at every opportunity. And again, this is one of the MEC principles as well, thinking about appropriate vaccination and pulmonary rehab, and also the social prescribing non-drug element of this as well. And if we think about the long-term plan, it's due for a refresh and out soon. But within that, it talks about life and the start to life. So if we think about pregnancy and women's health and then child health, so the best start to your life, then living your best life and living the best end of your life as well. So that's what the long-term plan aspirations are, and respiratory is one of the key areas within that as well. I mentioned health inequalities, and I think COVID has really spotlighted the difference in particular ethnic groups, and we know that I mentioned cost of living, that social deprivation is a concern. And the people, you can argue that the people who need the care the most don't often get it or can't access it for various reasons, and so we need to think about health in its totality as well. And in terms of air pollution, between 28 to 36,000 deaths per year happen because of air pollution as well. So we contribute to that. So what can we do to improve that? Also, there are other groups. So it might be people with disabilities or learning disabilities or children and young people. People fall through the cracks for whatever reason. So we want our care to be leveled up. We want to hear the voices. We want to give people the care that they need, and also the messages that they need to be able to look after themselves and contribute to the planet health as well. And I think this is quite a nice little picture that I put in sometimes, because it's telling us, really we want to aim for justice. That doesn't always happen, but equitable care, really, so that people can access the care that they need and there isn't massive variation. So there's still a lot of work along that lines nationally. So that takes me to some drivers and policy, which people will no doubt be aware of, but these are just some of them scratching the surface. So we've got the Health and Care Bill, we've had a climate emergency declaration, lots of hospitals have said it, and we've got the Climate Change Act as well. But if we think about our own NHS carbon net zero report, that came out in 2020, towards the end of 20, when everybody was still in the midst of the pandemic. So some of the messages took a little while to hit the system and for people to start taking action, but there has been work going on. Some areas were more early adopters to make changes, but lots of good things happened. But as I've said, we've got the NHS long-term plan, we've got the World Health Organization documents and air quality standards there as well. And what I wanted to highlight to people, you may have heard of the National Report on Asthma Deaths, the NRAD report. So that came out in 2014, and we are this many years on, and we're still doing really poorly in terms of our asthma outcomes. We had the All-Parliamentary Party Group for Respiratory Health report in 2020, but again, appreciating we had the pandemic, there was a year-on report that came out soon after, and we're still not doing very well. We have the worst asthma outcomes compared to the rest of Europe, and this is preventable. Nobody should be dying in this day and age from asthma, and Asthma Lung UK figures will pretty much echo the same. And then if we think about health in its totality, Sir Michael Marmot, his reports and his 10-year-on review, again, it's so stark, and we have to take a kind of wider health system approach as well to care. So there are some incentive schemes, so some from NHS England, some local things, and various medicines optimisation bits there. So hopefully your organisations and ICSs are signed up to them. And so this just shows the NHS net zero targets, which again, I'm sure people have seen this before. So in terms of inhalers, they kind of come under our scope 3. We know that within this, that carbon emissions from medicines are quite great, but within that, anaesthetic gases and inhalers are culprits. So the NHS have been taking lots of steps to decarbonise, and there's lots of different work streams. So again, they might not be specifically medicines. There is a medicine one there, but it's thinking about how hospitals function, adaptation measures, and also transport and travel as well. So there's lots of work going on. But coming back to the medicines, as I mentioned, we've got anaesthetic gases and inhalers being big culprits within that, and because of the volume of what they are, they do take up a lot of the they contribute to a lot of the carbon emissions. And some of the recommendations from the net zero report were to maybe move away from using meter dose inhalers and more dry powder inhalers, because they can still help people therapeutically but have a much lower carbon impact, and also to think about how we dispose and recycle our inhalers as well, and looking to doing things in different ways, so other innovations as well. So I've just put on here the duration of how long some of these greenhouse gases will stay in the atmosphere, and if you didn't already know and aren't shocked, I think if you look at the last one, the halocarbon, so these are the F gases, these are the ones that are inside our meter dose inhalers. And what I would just emphasize is that they are safe for inhalation to help propel the medicine out of the canister. They aren't great for the environment. They will sit in the atmosphere and not dissipate for a very, very long time. And so this is what's then causing this snuggly blanket around the globe, which is causing it to heat up, which is not good. So let's put that into context. So again, some of you may have seen these pictures before. If we think about an MDI, Ventolin brand, we're going to name and shame it today because it is one of the highest carbon footprint inhalers. And I think most parts of the country have moved away from Ventolin brand. So if you look at the carbon emission here, it's like a journey from London to Sheffield, which is massive. If you compare that to Ventolin brand dry powder inhaler, you've got a much significantly much smaller carbon footprint. So, I mean, there are other meter dose inhalers with a slightly lower carbon footprint than the Ventolin, but still they have a much higher emission compared to dry powder inhalers. And actually, if we think about what patients can use, most of our guidelines tend to suggest that patients start with an MDI, and that's traditionally what's happened. But actually, people don't often have the correct inspiratory flow. Some of them might, but most people don't. And so in terms of the best therapeutic care and lung deposition, we want people to be using the inhaler that's matched to them and their abilities as well. I've just put this slide up and I'm going to skip past it. So this was the Impact Investment Fund scheme, which is now not having these indicators. So the focus was to, again, try to look at the asthma and sustainability indicators. This has been unfortunately taken out of the GP contract. So there is a focus on patient experience and access, and all those patients with asthma, they haven't gone away, so they're still there. You can still see them and still do this good work to review their inhalers if you do work in primary care, but also in secondary care as well. So there's other national guidance which gives us a kind of a steer towards, you know, using inhalers appropriately and suggesting using lower global warming potential inhalers as well. And we have to think about the patient's choice and preference, but when there's no alternative to that MDI, then we want to choose the less bad option within that as well. And then there's lots of other quality standards and guidance from NICE. So if we think about for asthma and COPD, we want to aspire to those quality standards for care, and also shared decision making as well. So that is a big part of what the NHS England guidance was around these indicators. There's also the CPCS service, so patients are being seen more so in community pharmacy, so we want to give a shout out to them, but also make sure that they are adequately supported with the resources and that you know that you can actually refer to our community colleagues as well. I just want to highlight, people might be aware of this already because it's a little bit older now, but Prescript were working in partnership with NHS England and they published some nice resources. So there's inhaler carbon data, various audit tools, system searches and bits that you are able to download and use. If we think of other strategic levers and tools, we are taking more of a population health approach across the country. So you've got various tools like Shape and Fingertips, but also Prescript have got some information that you can use in their dashboards. And again, we're thinking about the levers. So better care for people, so less polypharmacy, thinking about deprescribing. You've got the Sequin for the discharge medicine scheme as well. And then again, I'd mentioned patients who might have more severe asthma. There's the AAC asthma biologics pathway as well. This is just showing the inhaler information on the Prescript site that you can look at, use their dashboard, and this is from Fingertips. So these are data intelligence tools that you can use as well, so people might have come across those. So you can see what's happening, what kind of dispensing is happening in your community pharmacies in terms of targeting patients. So let's think about net zero and how we link the policy to practice as well. So it's really about people power. So I'm really impressed that you're all here in an evening where you don't have to be here. And actually change is not easy, and people have different perceptions of what sustainability is and inhalers. And, you know, some people might think it's just about blanket switching inhalers, and that it's so much more than that. So I think what we do have is an opportunity to try to make care better for people with respiratory disease. That means we can take more of a focus on those people who are overusing SABAs and not using the treatments or adherent for whatever reasons, anybody with red flags and so on. And it's an opportunity to you know, educate and raise awareness, not just within our profession, but to people outside of our profession, really help to upskill. We need to think about the risks and the consequences as well of making changes if patients aren't properly supported. So we need to have follow-ups in place as well. And we don't want to destabilize somebody's lung disease because of an inhaler change as well. We've had the formation of integrated care systems just over a year ago now, but I think most people will agree that the system is in flux. We do have different work streams going on, and there's lots of competing priorities, and some of the jobs are actually being slimmed down. So actually there are different foci in different parts of the country, but everything is important. So it's about doing it and doing the right things right. And it would be remiss of me not to mention medicines optimization. So I'm going to refer to my RPS blog here, which outlines the 4 principles. But essentially, we want to reduce this preventable harm and give the patient the right choice of the medicine at the right time. And again, it's about choice. So we need to have those discussions with them. And so adherence comes into this. And as patients ourselves, we often will do a sort of a trade-off in our heads about, you know, what's in it for me? What does this mean to me? Do I need this drug? And maybe I don't actually have asthma, or actually I'll take my inhaler whenever it comes, and then I don't need to use it otherwise. So it's unpicking some of the myths that people have, and trying to get to grips with the adherence, because sometimes it's unintentionally non-adherent, but people's adherence will be impacted by their previous experiences as well. So we want people to have a positive experience. And for example, with smoking cessation, if they tried and not gotten on with a particular product, it'll leave a bit of a bad impression. But it's about, you know, working with the patient. You know, why do they not want to do something, or why do they end up, you know, not using their inhaler or treatment? And again, some people might think of it as a cyclical manifestation and not needing to use inhalers regularly, or they don't want to become addicted. And I've heard lots of different things, but it's about hearing it from the patient and how we support them to self-manage. So I've mentioned shared decision making a few times now. So care really needs to be patient-centered, and I guess it's making the patient see that, you know, what's in it for them, the wins. We don't want them to have antibiotics and steroids orally unnecessarily for exacerbations. And really, we have that AMR stewardship role there as well. So sometimes people might not be aware of their inability, their technique. So it's important for us to check that at every opportunity. And also people's medicines taking behavior changes over time as well. I think, as I've mentioned before, we need to think about non-medicine treatment. So thinking social prescribing, mindfulness, and the nose is part of the airways as well. And always encouraging people to be as active as possible. I mentioned air quality and indoor air quality earlier, and we've got the Child Health Lung Charter, but also the British Thoracic Society have got position statements on lung health and air quality. And there's also a sustainability one, which I'm part of their group, and it will be released early next year as well. So we want to prevent future deaths, and remember, these are preventable, and we want people to have better outcomes. I'm just going to flash up this slide around shared decision making. So this came out from NICE, and I feel like it's actually been a little bit tokenistic that organizations haven't really taken it on. So we talk about shared decision making, but do we know how to do it in practice? Does it happen as much as it should in practice as well? And part of that means that we need to, you know, give the patient all the information to make an informed decision. And, you know, as champions, are you able to go back and do some quick training, or make sure that the people in your clinics and your areas are able to support the principles of this as well? And I quite like the brand model here. So the benefits, risks, alternative, nothing. So this is quite good. And patients might not be ready to make a decision, and they might need some time. So it's about us giving them information so they can make an informed decision. And just a reminder that the law on informed consent changed about 4 years ago after the Montgomery case. So we really do need to explain to somebody, you know, what they can do, and that will help them if they're sitting on the fence. And, you know, if they don't want to make a change, whether it is an inhaler or something else, then at least they know, and they can have a discussion further down the line, depending on if their lung function changes and they're not able to get on with a particular treatment. But NICE have a suite of information, and there's also the Keele University app as well. So this is a good thing to try out if you want to try your skills out with shared decision making. You have various green plans that each ICS will have. So these are freely available. You can check on the internet, and everyone was required, all the ICSs were required to publish these. And also there is a lovely sustainability checklist that some colleagues, and I contributed to this as well, for Pharmacy Declares had produced. So it's there on their website that you can have a look at as well. So it's just thinking about sustainability in a number of different ways. Obviously there's a respiratory work stream, but also leadership, and we might think about our resources and infrastructure as well. There's other resources from Greener Practice. They're a wonderful group of people, and your local respiratory network might have other resources as well to share. So if I think about pharmacy's role within this, so pharmacists are known as sort of like the drug dealers, but actually we're pharmacy team. So we have techs and students and assistants and other staff as well. And we do lots of different things. And so really it's an opportunity to educate people who are non-pharmacy what we do and how we can be helpful, and tie into any work streams that they have which might be related to sustainability as well. Thinking about the bigger picture and understanding our carbon footprint as well. So if you don't know what your carbon footprint is, my challenge to you is, please, that if that's one thing that you do as an action from today, go and find out what it is. And there's lots of calculators that are available that are free. You can just look it online. WWF have one as well. But starting to make change isn't easy, but joining a movement is easier. So be part of a Mexican wave. You're here today, so that tells me something, that you are a self-selecting group. But you can join a community of practice or set one up, and really it's about allyship and advocacy, and understanding maybe what your infection control team are doing or your nursing colleagues. And it works both ways, and it's about that sharing information and what's going on in pharmacy. And just talking about pharmacy, I've mentioned there's a number of different drivers, but we have that joint national plan for inclusive pharmacy practice. So every part of pharmacy, we're one team. We can all work together in different ways, and that's across sectors and across systems as well. We've got various different services and various drivers here. So I talked about polypharmacy. So we've got the overprescribing report there. From a couple of years ago, got various guidelines as well. So different considerations and two-way communication across the system. So another thing that you might have seen, which again, very pleased to be part of this, was Greener Practice with Health Foundation produced a QI toolkit, and this is available again on the Greener Practice website. This is aimed at primary care, but there are lots of transferable messages, and I highly recommend you having a look at it. So what it's done is essentially put together a bunch of resources which are free. You can download them, use posters and educational material there, and you can take a QI approach, and there's 4 different ways of doing it, looking at your disease, device, disposal, and so on. And you can apply this in general practice as well. And this was really useful when the Impact Investment Fund first hit, because it was trying to guide people through how to target seeing patients. Now, although those IIF indicators aren't there in the same way, this is still a useful repository of information to use. So I would still consider, please, use it. And all those patients haven't gone anywhere; they still need reviewing as well. But in terms of doing more of this work, which is reviewing patients and having the conversations, the phone calls, and so on, who's going to do it? There wasn't really a lot of resource that came with the ask from the system, and so it's about various roles and responsibilities and the confidence and competence that goes with that, and what kind of resources and support do you need. So what's happening in your place of work, who's doing what, and a bit of a gap analysis, and what needs to change, and what support do you need if you need to do things differently or better. So just to think about that. And then some quick tips for high quality sustainable asthma care. So I won't read them all out, but I have spoken about SABA overuse. So really we want to try and target this, because some people are prescribed SABAs, they don't have a diagnosis formally. They have a SABA on its own, and they don't have inhaled steroid, and they've got asthma, which is quite worrying. So it's just trying to root out these patients and give them a once over. and trying to review and then address non-adherence where it might be happening, and optimizing that inhaler technique at every point. And again, I think I'd mentioned earlier that most people, when they get started on an inhaler, get put straight on an MDI. And MDIs, if they are being used, they need to be used with a spacer to be really effective, and people need to know how to use that and then care for the spacer. But actually, most people get on better with a dry powder inhaler, and it's much better for the environment as well. So device changes shouldn't be happening just because. They should be happening where it is clinically appropriate and where you've had that shared discussion with the patient, and make sure there is a follow-up in place to make sure that the patient hasn't been destabilized as a result of a change. We want people to be able to self-manage and have that confidence. So use of asthma action plans, not just in name, but so that the patient can show you and they do know, actually, when my peak flow falls below this, I know what to do. And so that's important. What we want to do is also make sure that we're able to streamline, where possible, the devices that patients use, so that it's not a dry powder here and then a MDI over there, and lots of different things. So trying to, where you've got combinations or the same type of device, trying to keep it consistent is helpful for the patient as well. And then it might be that you use a higher strength inhaler and just use less puffs, but I would just be careful that we're not accidentally confusing our patients if that's happening. So we don't want people to be overdosing by accident on a steroid, for example. So just being responsible and thinking about adrenal insufficiency there. And then pointing them to reputable supportive resources. And again, a take-home message for anybody with inhalers, that they must not go in the domestic way. So please, whether the patient has stopped using it, it's expired, part used, whatever it is, any inhaler, whether it's an MDI or otherwise, it needs to come back to pharmacy for appropriate disposal. So as I said earlier, we have a bit of an opportunity, although we have this crisis. So it's about improving that quality of care, which we can do, I think. And I've said also not to have a rote switch of MDIs, but consider dry powders and the clinical appropriateness. And for people who are just starting out with making changes, really it's about how we're working with our local system. So understanding the figures. So what's your prescribing data? What's going to be the economic impact and the modelling of any changes that you're going to make? So taking a QI approach is often a good way to approach this. And then this is going to require a system change. So a lot of places have already changed their formulary, and it's really connecting and raising awareness for colleagues who are not medical, who are not pharmacy, to help them understand that, yes, the pound signs are flashing because there is going to be a cost because we're changing to X, but actually it's a cost that is downstream. We're saving an admission, or we're doing things that are better for the environment as well, because it's everyone's problem. I've talked about disposal, and I think sometimes people forget how long an inhaler lasts. So if you had 100 doses in a inhaler and you were using 1 puff a day, then that's going to be 100 days. So often patients don't understand. So again, it's reminding them and giving them a little bit of assurance. And just, a panic attack, sometimes people will get panicky and mistake that for an asthma attack or needing to use their inhaler. So again, just other tips and tricks for mindfulness and just being aware of their breathing as well. So yeah, that's important. And then, do you have a pharmacy sustainability strategy? So a lot of places should have a green plan, but do you have a local strategy? And if not, is that something you could create? And what is happening in your local area and other hospitals as well? So nearly at the end now. So just thinking about you in your current role and what you're doing, you might be working actively with respiratory care, you might not be, but I think any change that you're trying to make within any sustainable kind of work, we want to look at what is the scale of the problem, try and understand the carbon impact, and that if you're wanting to make a change, can you do some modelling, some financial modelling, some carbon impact modelling, and really thinking about what is our future state. So understand our current state and how we're going to get to our future state as well. Think about what levers you have. So there's lots of national and strategic documents and levers. And then think about the implications of the change that you're going to make. So with inhalers, it might sound like, oh, actually, this is much easier and there's a cost pressure and there's a SIP, let's do this. But actually, what is that going to mean for a patient? Who's going to make those changes? How's that going to happen? And is the shared decision making going to happen within that? And what resources has the person, whoever that is, that's going to be doing these changes, have they got to support them as well? And how do we inform our patients that this is happening? I've heard lots of bad stories of patients being given a text message, sent a text message about changes, and they're not involved in the conversations, despite all the good work that's gone on to try and raise that awareness as well. So patients as partners within all of this as well. Again, always to be encouraging smoking cessation, returning and recycling of our medicines, whether they be blister packs or inhalers or otherwise. And actually, again, thinking about the opportunity, we have an opportunity to do things smarter, not harder. So look at our processes. Is there any waste within them? So can we do things in a more lean way? So this is not just a top-down approach, you know, NHS England telling us to do things or certain bodies telling us to do things. This is something we really need to do bottom up as well, and bring in relevant stakeholders as well. And just a little plug here, people will think, you know, what's in it for me? And as pharmacists, I think it's really good to think about your own development and thinking of competence framework. So we've got the APF there for advanced and consultant practice. And within that, you've got the research domain. So doing any audit, evaluation, QI work will contribute towards that. So just if you're looking at a reason why you need to do it in just a kind of professional sense, that's one way of doing it as well. And just also to give a little plug to the RPS Green Pharmacy Guide, which is out for consultation. So if you haven't already had a chance to look at it, please do. If you've got any comments, I know Minna's online as well, we'd appreciate comments on that. But it's there to help you achieve the carbon reductions in the pharmacy workplaces as well. And just another thing to think about is circular economy. So this is really how we manage our resources, how we make and use our products, and then what happens to the materials afterwards. So this is, you know, about waste and use of medicines generally, as well as other things as well. So thinking about what else you can do. So join a sustainability network if you haven't already. Find people who are interested in your green pals. You can become a green champion, and it might be that you feel like a little bit of a lone voice where you are, but there are lots of people who are interested and willing to support with resources or a friendly chat or you know, a critical eye on something that you might be doing. So there's lots of support in the pharmacy world and outside of pharmacy. So you know, make use of that. There are offers of carbon literacy training if you want to know more about that. And also, as I've mentioned, think about other things. So there's the NHS Leadership Academy Sustainability course and also the School for Change Agents as well. But think about your own carbon footprint. Is there anything that you can improve on? And really listen to people who might be saying, oh, no, this doesn't apply to me. And why is it? Why do people think that, you know, it doesn't apply to them? Because it's everyone's business, and slowly with your magic you'll be able to drip feed into them you know, the importance of sustainability within healthcare and take people on that journey with you as well. So in our personal and professional lives, there are other things that we can do which are around active travel, for example, living in a kind of healthier way, which is good for us as well as the planet, more plant-forward diets, thinking about diverting from fossil fuels and banks that we bank with as well, because some are less green than others as well, and obviously the use of plastics there. So this slide just sort of encompasses the key respiratory sustainability messages that I've already alluded to. So use the lower carbon option where possible. Now, if we want to change over a patient to a dry powder, then great, let's do that. Think about shared decision making, think about the steroid and antibiotic stewardship, keeping people well and empowered and so on. And the patient is the partner throughout all of that. So I keep saying we're nearly at the end. We really nearly are. We are awaiting the joint national asthma guideline next year. So that's the NICE, BTS and SIGN guideline. We have got more of a shift of pathways now. And the London inhaler formulary has been in development for a while, and I'm hoping will come out next year as well. There are new lower HFA propellants also on the horizon. And as I've said, people are trying to do things in different ways. So change their pathways, leaner working, care closer to home as well. So the use of virtual wards and, you know, keeping people in their houses and alternative to being in hospital as well. We've got a change to the commissioning landscape as well. So severe asthma services services and ILD services will be moving their delegation to ICBs from next financial year for those ICBs that are ready to take on that local leadership. So you might be involved in some of this. So it's thinking about how we deliver medicines, for example, and we're not having lots of waste within that. And just thinking about ultimately what we're doing is the triple bottom line. So it's thinking about the financial, the social and the environmental elements within this. There are IPC challenges as well, but there's lots of positive changes that are happening across the country. So you might have heard of the Gloves Off campaign, and people are trying to reduce their single-use plastic. So just being sensible. Do I need to wear gloves for a procedure that I'm doing, etc., and so on. And I've put a little link in here to a paper. It was more to remind myself, because people will say, actually, what's the evidence? So this is an opinion article which discusses the use of dry powder inhalers versus MDIs, and patients can very easily, very well use DPIs as opposed to MDIs, and often do better as well. So the reference is there. So I really am at the end now. So thank you for bearing with me. But essentially what we want to do is make it easier to do the right things right. So enable the patients, enable the people that we work with, whether it's our respiratory nurses, whether it's people in the ICS, etc. And we don't want to do blanket inhaler switching. We want to make sure that the patient is the partner. They understand what's being told to them. They are making an active choice, and they're choosing the greener choice and what's best for them as well. We want to keep them well and think about efficiencies and value. So again, it's not just about cost improvement and box ticking, because that might be a short-term gain with longer-term pain as well. So really that whole system approach, making every contact count as well, and that shared decision making. So really, what do you need to do? What's your takeaway from today? Think about what are your local green plan targets, and is there anything different that you're going to do? And I'm just going to end us with this cycle that I flashed up at the beginning. So I don't know at the end of this this talk whether you have moved anywhere along the cycle, but it'd be really great to get people more engaged as well as being more aware and curious. So thank you very much. I will stop talking now and open to questions, and hopefully I can stop sharing.